Examination of the peripheral blood film in correlation with the complete blood count. So the peripheral blood examination is a diagnostic tool that provides important information about the patient's hematologic status. It can help identify infections, inflammation, hematologic disorders, and can help guide clinical management. Some components of this evaluation. So the peripheral blood exam typically will have a white blood cell estimate. This is an estimation of the total number and types of white blood cells, which can help detect infections, inflammation, leukemia, and even immune disorders. Platelet estimates. This is an evaluation of platelet count in the morphology to assess bleeding and clotting disorders. Relative proportion to white blood cell types, so differential counts of various white blood cell types such as neutrophils, lymphocytes, monocytes, eosinophils, and basophils, which can provide insight into specific disease processes or immune responses. Cell morphologic structure, so examination of red blood cell size and shape abnormalities, including macrocytes, which are large cells, microcytes, which are small cells, anisocytosis, which is the size variation, poikilocytosis, which is the shape variation, in presence of inclusion bodies, which can assist in diagnosing different types of anemia and other disorders. For specimen collection, so for peripheral blood examination, proper specimen collection is going to be essential to help ensure that we get accurate results. EDTA, this is the most commonly used anticoagulant for hematology specimens. EDTA anticoagulates the blood by chelating the calcium that is essential for coagulation. Blood collected in ETA tubes should have slides prepared within 4 hours at room temperature for optimal cell morphology. Some advantages of using EDTA include the ability to prepare multiple slides from one specimen and its effectiveness in preventing platelet clumping, which can interfere with the platelet count. However, there is a notable limitation in platelet satellitis, where platelets can adhere to white blood cells in some patients, which could potentially cause inaccurate counts. We also can use sodium citrate. This is an alternative anticoagulant that can eliminate some of the limitations seen with the EDTA, such as that platelet satellitis. Because sodium citrate dilutes the blood sample, a dilution factor of 10 to 9 must be applied, meaning platelet and white blood cell counts should be corrected by multiplying by 1.1 to reflect the true values. For finger or heel punctures, so blood collected via finger or heel puncture can be directly placed on slides for examination, but this method has limitations such as platelet clumping if the slide is not prepared quickly. Microtainers, commonly used for capillary collections, also have limitations related to volume and clotting risk, which may impact sample quality. To prepare a slide, there are a couple different techniques. The first one is the manual wedge technique. So the most commonly used method for preparing peripheral blood films is this manual wedge technique. In this method, a drop of blood is placed near one end of the slide and a second spreader slide is used to pull the blood across, which creates a thin feathered edge suitable for microscopic examination. So the slide characteristics, we will have a well-prepared blood film, and it should have a gradual thinning of cells from the thick end to the feathered edge with a monolayer of well-distributed cells in the optimal examination area. The smear should be free of streaks, holes, or irregularities that could obscure cell morphology. The procedure for this, so to perform the manual wedge technique, place a small drop of blood near the frosted end of the clear slide. Hold the spreader slide at a 30 to 45 degree angle and draw it back to touch the blood drop, allowing the blood to spread along the edge. Then push the spreader slide forward smoothly and evenly across the slide to create the smear. So features, if you have a well-made peripheral blood film, it's going to be, you'll have an even distribution of cells with minimal clumping. You'll have a thin feathered edge with individualized cells that are clearly visible under the microscope. You'll have absence of thick areas or holes, and preservation of cell morphology without distortion would be viewable. We can also make a slide with an automated slide maker and stainer. So automated slide makers and stainers improve standardization and efficiency in slide preparation. The procedure involves automated spreading of blood onto slides followed by rapid staining, often using the right Giemsa or similar stains, which reduces human error and variability. Automated systems allow for high throughput in clinical laboratories and provide consistent slide quality for reliable microscopic evaluations. After preparing a peripheral blood smear, drying is an essential step to preserve cell morphology and to prevent artifacts. Films should be dried quickly and evenly, preferably by air drying at room temperature. Avoid excessive heat or prolonged drying, which can cause distortion or even shrinkage of cells. Improper drying can lead to artifacts such as cell shrinkage, crenation, or morphological changes that could complicate microscopic interpretation. Staining enhances the visualization of cellular components, and it is vital for accurate morphological assessment. The most commonly used stain is the Wright Giemsa stain. This is a polychromatic stain that provides excellent differentiation of cellular structures. So the staining procedure generally involves fixing the dried smear with methanol, followed by application of the stain solution for a specific time, rinsing with a buffer or water, and then drying again. The exact staining times and buffers could differ depending on which kit you're using. So just make sure you look at those and you know exactly what you're doing, because if you have the wrong time, the wrong buffer pH, it could affect staining quality. For staining characteristics, so we have acidic components, so like DNA, RNA, and the cytoplasmic RNA. Those will stain blue to purple due to an affinity for basic dyes like the methylene blue. For basic components like hemoglobin and eosinophilic granules, these are going to stain pink to red due to the affinity for acidic dyes like eosin. Some artifacts in staining can occur due to improper staining techniques, including overstaining, understaining, precipitate formation, or uneven staining. These may mimic or obscure cellular abnormalities, so proper techniques and quality control are essential. The manual Wright staining method involves applying Wright stain to a dried peripheral blood smear, allowing the stain to act for a specified time, followed by rinsing with buffer and drying the slide. So the procedure, you're going to flood the dried smear with Wright stain, allow the stain to sit for 1 to 3 minutes. We're going to add a buffer, which is usually at a pH of 6.4 to 6.8, to the stain on the slide, and we're going to mix gently. Let it stand for an additional 4 to 6 minutes, and then we're going to rinse gently with water and air dry. Once again, this could vary by kit that you're using, so make sure you double check, but that's the typical. Some disadvantages: time consuming, and this requires about 10 to 15 minutes of hands-on time. There's a risk of spillage or inconsistent staining if timing or technique is not carefully followed. And there's also variability due to manual handling, which may affect reproducibility. Then we have an automated Wright staining method where there is a slide stainer which will stain it for you. So automated slide stainers use the same staining principles but can actually help streamline the process with machines. So the procedure, generally the slides are loaded into the stainer where staining, rinsing, and drying steps are automated and standardized. Advantages of this is it's a rapid turnaround time. Again, it's about 5 to 10 minutes, but it's hands-off. You don't have to actually be there to do the steps. It's consistent and reproducible staining quality, and it's useful for handling large volumes of slides and urgent or stat samples. Some disadvantages: the stains in automated systems are typically stable for only 3 to 6 hours, so it requires frequent replacement of those stains. The initial cost of equipment and maintenance may be high as well, and it also has a limited flexibility for customized staining protocols. So there are also quick stains for the Wright staining method. So the quick stains are modified Wright stains, which are designed for rapid staining of peripheral blood smears, and these are usually completed within about 1 minute versus the 10 to 15 of the other one. The procedure typically involves applying the stain to the slide, a brief incubation, and then rinsing and drying, which allows for a very fast turnaround time. Advantage: speed. It's completed in about 1 minute, which allows rapid processing of slides. It's efficient, so it's suitable for urgent situations where quick results are needed, and it's cost effective. It requires fewer reagents in less time, which makes it economical for high volume labs. But of course, there are some disadvantages, so quality is one of them. Quick stains often provide less detailed cellular morphology and may compromise staining quality compared to standard Wright Giemsa stains. It may result in less optimal differentiation of cell components, which could potentially affect diagnostic accuracy. For a microscopic examination of peripheral blood films, it's essential for confirming automated results, identifying abnormal cells, and diagnosing hematologic disorders. So first, you're going to do a macroscopic examination. This is the initial visual inspection of the blood smear for uniformity, thickness, color, and presence of clots or artifacts which will help guide further microscopic evaluation. So this is usually done at a higher 10x objective. For microscopic examination, so this involves using different objective lenses to evaluate various features. We're going to go up to the 40 or 50x. The objective for this is it's used for more detailed examination of the cell morphology, including size, shape, and identification of abnormal white blood cells. And then you're going to go all the way up to 100x, which is the oil immersion objective, and that provides the highest magnification to examine fine cellular details, such as nuclear chromatin, cytoplasmic granules, and subtle morphological abnormalities. The optimal area for detailed examination is usually the monolayer region of the smear, where red blood cells are evenly distributed without overlap, allowing an accurate assessment of cell morphology and differential counts. For a white blood cell differential, the procedure. So the white blood cell differential involves manually counting and classifying usually 100 white blood cells on a peripheral blood smear to identify the white blood cell types and detect any abnormalities. So in samples with elevated white blood cell counts, fewer fields may need to be examined to reach the target cell count because there are, an abundant amount of white blood cells in the sample. So in cases of low white blood cell counts, more fields and slides may need to be reviewed to count enough cells for an accurate differential. For the side margin cells, so cells located along the side margins of the smear, they are generally excluded from the count to avoid counting partially distorted or artifactually altered cells. So for abnormalities during the differential review, attention is going to be given to the morphological abnormalities such as toxic granulation, vacuolization, hypogranulation, nuclear segmentation defects, or presence of immature or atypical cells that may indicate infection, inflammation, or hematological disease. For reporting methods, so results are usually reported as percentages of each white blood cell type and absolute counts when correlated with the total white blood cell count. The modern hematology analyzers can automatically locate and identify cells on blood smears using digital imaging and software algorithms, which can enhance speed and accuracy of differentials while reducing manual workload. The red blood cell microscopic examination. So we're going to look at the size of the cells. So the cell size is assessed to help classify red blood cells as normocytic, microcytic, and or macrocytic, which can help aid in anemia diagnosis. We're going to look at the variation or the anisocytosis in the cells. The presence of anisocytosis indicates variability in red blood cell sizes, often seen in disorders like anemia or following blood transfusions. We're going to look at cell color or polychromasia and hypochromasia. So cell color reflects hemoglobin content. Hypochromic cells appear pale due to low hemoglobin, while polychromatic cells show a bluish tint indicating reticulocytes or immature red blood cells. We're going to look at the cell shape as well, so that would be called poikilocytosis. So abnormal red blood cell shapes such as target cells, teardrop cells, or even sickle cells can help identify specific hematologic conditions. We're going to look for any inclusions too. So inclusions inside the red blood cells like Howell-Jolly bodies, basophilic stippling, or even the Heinz bodies, they can provide clues to underlying pathology like splenic dysfunction or hemoglobinopathies. We're going to look at the correlation with automated parameters. So the microscopic findings are correlated with automated hematology analyzer parameters such as MCV, MCH, and RDW to help provide a comprehensive assessment of blood cell morphology and aid in diagnosis. For the platelet estimate is performed by examining peripheral blood smears under the oil immersion objective, which is the 100x, and counting the average number of platelets in several fields. Typically, platelets are counted in 8 to 10 oil immersion fields to calculate an average number per field. The calculation, it's a normal calculation, so the estimated platelet count is calculated by multiplying the average number of platelets per oil immersion field by 20,000. This provides an approximate platelet count per microliter of blood, and then you can compare that to what the analyzer gave for a platelet count just to verify that everything is where it should be. For calculation, when number of red blood cells per field is low. So if the red blood cell count per field is low due to a thin smear or other factors, the platelet estimate may be adjusted or confirmed with an automated platelet count for accuracy. So organization of red blood cell results. So phase 1 is you have the summation of data. This phase involves compiling and summarizing the complete blood count data using appropriate hematologic terminology. It includes reporting values such as hemoglobin, hematocrit, red blood cell indices, white blood cell counts, and platelet counts. Phase 2 is the recognition of patterns. In this phase, the clinician or laboratorian identifies patterns in the CBC results that are consistent with specific diseases or disorders. So recognizing these patterns can help guide diagnosis and further testing for the patient. So assessing hematology results relative to the reference intervals. So white blood cell parameters. So the white blood cell counts are evaluated against reference intervals that vary by age and sex. Deviations may indicate infection, inflammation, or hematologic disorders. For red blood cell parameters, the red blood cell counts, hemoglobin, hematocrit, and red blood cell indices are compared to age and sex-specific reference ranges. Abnormal values can help classify anemias and other red blood cell disorders. For platelet counts and parameters, so platelet counts and volume measurements are assessed relative to reference intervals adjusted again for age and sex. Variations may suggest thrombocytopenia, thrombocytosis, and or platelet function abnormalities. For reference ranges are dependent on patient sex and age, emphasizing the need for context-specific interpretation. Some strategies to determine significance of results. So you're going to want to compare results to reference ranges considering the patient demographics, correlate results with clinical findings and history, use patterns of multiple parameters rather than isolated values, and repeat testing to confirm abnormalities or monitor trends. Summarizing white blood cell parameters. So ensuring an accurate white blood cell count. So an accurate white blood cell count it's critical for diagnosing infections, inflammation, and hematologic diseases. We need to make sure there's proper specimen collection, handling, and analysis techniques are used, and they have to be followed. So the total white blood cell count provides an overall measure of circulating leukocytes in the blood and is the basis for further differential analysis. Some terminology, so we have the white blood cell differential. This is the distribution of different types of white blood cells, so neutrophils, lymphocytes, monocytes, eosinophils, and basophils, expressed as percentages or absolute counts. Then we have the relative counts. This is the proportion of each white blood cell type as a percentage of the total white blood cell count. Absolute counts, these are the actual number of each white blood cell type per microliter of blood, calculated by multiplying the total white blood cell count by the relative percentage. Some problems we can run into, so issues such as clumping, inadequate smearing, or instrument limitations may affect the accuracy of the white blood cell count in differentials. For calculations and terminology, so we have an absolute count that equals the relative percent of a white blood cell type times the total white blood cell count divided by 100. Absolute counts are preferred for clinical interpretation as they actually reflect true cell numbers independent of shifts in other cell populations. For white blood cell abnormalities in the white blood cells can indicate infection, inflammation, bone marrow disorders, or hematologic malignancies. Presence of immature white blood cells, such as band metamyelocytes or myelocytes, usually reflect an active bone marrow response to infection or stress, which is often going to be described as a left shift. So a left shift refers to an increased number of immature neutrophil precursors in the peripheral blood, signifying heightened marrow activity or inflammation. For white blood cell morphologic abnormalities, these could include changes in size, shape, nuclear configuration, and cytoplasmic features of white blood cells, which could point to specific diseases or reactive processes. We can also look for white blood cell inclusions. These inclusions could include toxic granulation, Dolly bodies, or Auer rods could be observed, and they can help in the diagnosis of infections or even leukemias. For white blood cell morphology, this is a detailed examination of white blood cell morphology, and that provides valuable diagnostic clues, complementing automated counts and differentials. For your red blood cell, so we have your total red blood cell count. This measures the number of red blood cells per microliter of blood, which is important for assessing overall erythrocyte quantity. Hemoglobin is the concentration of hemoglobin in the blood, reflecting oxygen carrying capacity. Hematocrit is the percentage or fraction of blood volume occupied by red blood cells. The MCV, or the mean cell volume, is the average volume of individual red blood cells used to classify anemias as microcytic, normocytic, or macrocytic. The mean cell hemoglobin, or the mean MCH, is the average amount of hemoglobin per red blood cell. MCHC, or the mean cell hemoglobin concentration. This is the average concentration of hemoglobin in a given volume of packed red blood cells. The RDW, or the red cell distribution width, is a measure of the variation in red cell size, so anisocytosis. Morphology, this is the examination of red blood cells' shape, size, color, and presence of any inclusions, which can help aid in the diagnostic information for the provider to give to the patient. For hemoglobin and hematocrit, we follow the rule of 3. So when the red blood cell morphology is relatively normal, like normocytic and normochromic, the hematocrit can be approximated by multiplying the hemoglobin concentration by 3. So you would take the hemoglobin, multiply that by 3, and the hematocrit should be about, plus or minus 3 from that, and that should be a good indicator to double check. So this rule serves as a quick quality check and helps identify possible errors or abnormal red blood cells. Hemoglobin concentration is a key indicator of anemia, and it is lower than normal hemoglobin levels can suggest anemia, but further classification is going to depend on your red blood cell indices and morphology. The MCV, so it corresponds to the average size of the red blood cells. Red blood cell histograms display the distribution of red blood cell sizes, so the MCV is actually derived from these distributions. Morphology on blood smear confirms the size findings, so if they're microcytic, normocytic, or macrocytic. We have some relationship for classification of anemias, so the MCV, as mentioned before, is essential in classifying these anemias. We have microcytic anemia, and that is when the MCV is less than 80 femtoliters. Normocytic anemia is when the MCV is between 80 and 100 femtoliters, and macrocytic anemia is when the MCV is greater than 100. Again, normal ranges are between 80 to 100. If we have a decreased MCV, it could be a caused by iron deficiency anemia, thalassemia, chronic disease anemia, or sideroblastic anemia. If you have an increased MCV, it could be from vitamin B12 or folate deficiency, liver disease, alcoholism, hypothyroidism, or even just caused by certain medications. For the MCHC, so the MCHC reference range is between 32 and 36 grams per deciliter. This indicates normal concentration of hemoglobin in red blood cells. If we have decreased values, we're going to call this hypochromic. So the MCHC is below those normal indicated levels, which is decreased hemoglobin concentration per red blood cell. This is going to be common in iron deficiency anemia, thalassemia, and chronic disease anemia. If we have increased values, you could, spherocytic red blood cells is kind of the first thing that comes to mind. So these elevated MCHCs can be seen in conditions where spherocytes, where red blood cells are more densely packed with hemoglobin, such as in hereditary spherocytosis or autoimmune hemolytic anemia. The RDW, or the red cell distribution width, this measures the variation in red blood cell size or volume. It provides information about anisocytosis, which is the degree of variation in red blood cell sizes within a sample. So if we have an elevated RDW, it can indicate greater variation in red blood cell size. Some common causes for this are iron deficiency anemia, vitamin B12 or folate deficiency, recent hemorrhage or hemolysis, and thalassemias. Some indications for right stain peripheral blood film examination. So we do not perform a manual differential on every single thing that comes down into the lab. So when we do perform them, it's usually due to any abnormal red blood cell parameter from the automated analyzer that could suggest anemia. Abnormal red blood cell indices and deviations from the rule of 3, which could indicate possible abnormal red blood cell morphology. So when to evaluate the red blood cell morphology, we're going to look at the size. We're going to see if it's microcytic, normocytic, or macrocytic. Shape, so poikilocytosis, we're going to look for spherocytes, elliptocytes, target cells, etc. Inclusions, those Howell Jolly bodies, basophilic stippling, and Pappenheimer bodies. In mature red blood cells, we're going to look for presence of nucleated red blood cells or reticulocytes. For color, we're going to look for hyperchromia or polychromasia. In clumping, we're going to look for rouleau formation or agglutination. So reporting abnormal red blood cell morphology, we have a standardized morphology criteria. So we use consistent and standardized terminology to describe red blood cell abnormalities. We're going to report findings such as size variations. We're going to report that as microcytosis or macrocytosis. If there's any shape abnormalities, we would do poikilocytosis in the types. Presence of any inclusions in color changes. We're going to quantify abnormalities when possible as mild, moderate, or marked, and each lab kind of has their own criteria for, if it's going to be mild, moderate, or marked, so make sure you know what you're looking at there. For value of reticulocyte count and reticulocyte production index. So the reticulocyte count assesses bone marrow response to anemia. The reticulocyte production index corrects reticulocyte count for degree of anemia and maturation time. This helps differentiate anemia with adequate marrow response, so hemolysis or hemorrhage. Anemias with inadequate marrow response too, so aplastic anemia or marrow failure. Summarizing your platelet count, so your normal platelet range is usually 150,000 to 400,000. Increased values are going to be called thrombocytosis, where your decreased values are going to be called thrombocytopenia. We have a measurement called MPV, or mean platelet volume. This is measured in femtoliters, and this indicates the average size of platelets. So the larger the MPV may suggest an increased platelet production or activation. So platelet morphology, it is important to evaluate platelet size, shape, granularity, and if there's any clumping on the peripheral smear. So the relationship with with white blood cell and hemoglobin. So pancytopenia means it's the reduction in platelets, white blood cells, and red blood cells, where pancytosis means that there's an increase in all three of those. So there's an increase in platelets, white blood cells, and red blood cells. And continuing on with the MPV, so your normal values will typically range from 7.5 to 11.5 femtoliters, and it may vary slightly by each lab, but that's around the general. Increased values of your MPV can indicate larger platelets, may reflect increased platelet production or younger platelet populations, and this can be seen in conditions like immune thrombocytopenia, recovery from thrombocytopenia, and even in some myeloproliferative disorders. We're going to do a visual inspection of the platelet diameter as well. So platelet size can be visually assessed on the peripheral blood smear. This can help to confirm the automated MPV calculation. So problems with MPV, there is variability due to different analyzer technologies. Sample handling and anticoagulants can play a role, and if there's any time delay between sample and collection and the analysis can also be affected. So MPV values can also be affected by platelet clumping or platelet fragmentation. There are new measurements available, so some modern analyzers provide additional platelet parameters, such as platelet distribution width, immature platelet fraction as well. These offer a more detailed assessment of platelets, and I'm sure as time goes, they'll come out more. All right, so summarizing platelet morphology, we're going to look at platelets versus giant platelets. So large platelets are slightly bigger than normal, often younger platelets released early from the bone marrow, whereas giant platelets are much larger than normal platelets, often seen in inherited or acquired platelet disorders. So bizarre or dysplastic platelets, these are abnormally shaped or structurally abnormal platelets. They may indicate underlying bone marrow disorders or myelodysplasia. For granularity, normal platelets have fine, evenly distributed granules. Altered granularity may suggest platelet activation or dysfunction. We're going to look at the arrangement of platelets as well. So are they clumped? If platelets are sticking together, it may cause falsely low platelet counts, and this is common in EDTA anticoagulant samples. Is there satellotosis happening? So platelets surrounding neutrophils. This happens in some patients, doesn't happen often, but again, that's actually what the picture shows down below. You have those little purple dots around the white blood cell. Those are actually the platelets, and that is called satellotosis. And this can interfere with automated counts as well because it's not going to count them appropriately because it's hanging around the white blood cell.